Clearly, over the last few years, the drugs that have created the most amount, or has garnered the most attention, is the immune checkpoint inhibitors, specifically PD-1 targeted agents. We have, as of now, two PD-1 inhibitors that have been approved for the treatment of recurrent non-small cell lung cancer, pembrolizumab and nivolumab. And actually, pembrolizumab recently received approval for patients whose tumors have high PD-L1 expression as frontline therapy. However, the PD-1 pathway can be also targeted by antibodies that target PD-L1, the ligand for PD-1 receptor on the T cells. OAK was the first randomized phase 3 study evaluating an anti-PD-L1 antibody in the management of advanced non-small cell lung cancer patients. The primary analysis of this study was presented by Dr. Barlesi at ESMO this year, and the primary results of the primary analysis showed that atezolizumab improved survival compared to docetaxel in patients who had received either 1 or 2 prior lines of therapy and had developed disease progression with a hazard ratio of 0.73. At this year's meeting at the WCLC, I'm going to be presenting subgroup analysis of this randomized phase 3 study. We did this subgroup analysis to evaluate the efficacy of atezolizumab compared to docetaxel in a variety of clinically relevant subgroups of non-small cell lung cancer. The first subgroup we analyzed was based on the PD-L1 status of the tumor, but as assessed by PD-L1 gene expression. So PD-L1 status in the past has been primarily been assessed by immunohistochemistry, but this analysis was based on PD-L1 gene expression, and patients were divided into 2 groups. A high group that included patients whose tumors had PD-L1 gene expression greater than or equal to the median tumor gene expression, and a low group that had lower than median PD-L1 gene expression. And atezolizumab improved survival compared to docetaxel in both groups of patients. Thus, this is the first study that showed that a PD-1 directed therapy provides greater survival advantage or greater survival than docetaxel, irrespective of the PD-L1 status, either assessed by immunohistochemistry or assessed by PD-L1 gene expression. We also analyzed the efficacy of atezolizumab compared to docetaxel in patients who had CNS metastases, and the analysis showed that it provides very similar survival advantage as the overall patient population. In addition, we also identified that atezolizumab improves survival compared to docetaxel in never smokers as well. This is important because previous data from PD-1 directed therapy has shown that these drugs may not provide survival advantage compared to docetaxel in never smokers. So the fact that in this subgroup analysis of the OAK trial, atezolizumab did improve survival compared to docetaxel in never smokers does appear to be meaningful. We also assessed the survival with atezolizumab in EGFR mutation positive non-small cell lung cancers. And like other PD-1 directed agents, atezolizumab did not improve survival compared to docetaxel in EGFR mutation positive non-small cell lung cancer patients. Finally, we looked at benefits across age groups, and including in the very elderly patients above the age of 75, atezolizumab improved survival compared to docetaxel in all age groups. So what this subgroup analysis showed was that atezolizumab improved survival compared to docetaxel in all subgroups of non-small cell lung cancer patients. And it also showed benefit in certain subgroups where previous PD-1 directed agents have not shown benefits, such as never smokers. And it warrants further investigation into possible differences in activity of PD-1 directed antibodies versus PD-L1 directed antibodies.